Today I'd like to discuss some easy way to do sinus lift techniques. There are many techniques available today, some involving lateral window technique, some involving Cresta approach. I would like to share with you what we have been doing in our office, which is fairly simple and easy procedure. As you can see, maybe my son is too young to do this procedure, but I believe that any dentist, any licensed dentist can follow these techniques. Before I do any kind of lectures, I always give thanks to my great mentors. I'm very fortunate to have great mentors. I would like to thank Dr. Kwan and Dr. Park for introducing implant dentistry for me, and I don't think I'll be here today speaking in front of you if they didn't teach me what they have taught me. Today, I would like to challenge current dogma in implant dentistry, especially in sinus grafting. I believe that we need to have new criteria for deciding whether to go lateral approach or Cresta approach. And I'll be discussing the new criteria with you later on. And I believe that the technique I will be describing today, called Cresta window technique, should be the gold standard rather than the lateral window technique. Let me do a little bit of literature review before we actually go into detail into this technique. As you know, there's two major techniques available. Caldwell log procedure, which is known as the lateral window technique, and also Cresta approach, such as a Summers osteotome or any other tools out there that you're used to. As you know, lateral approach involves more bigger flap, more invasive procedure for the patient. Therefore, it's not uncommon to see swollen face, such as on the left, with a lot of swollen and pain 1 week after the procedure. In contrast, Cresta approach, as you can see, has very little morbidity, and patient can even go play golf the next day. And I had privilege to treat my classmate, my dental school classmate. We did lateral window approach on the left and Cresta approach on the right, and he told me it's about 10 times more painful when he had lateral approach done compared to the Cresta approach. Another reason why a lot of clinicians do not like to do lateral window technique is because of this artery that you can encounter during the window making of the lateral window. And many literature have described this artery, which could be a nerve-wracking for a general practitioner opening a lateral window. In contrast, as we know, there is no arteries to deal with when we do a Cresta approach. I don't think anybody drives with their blind eye. Therefore, Cresta approach is good, it's minimally invasive, but blind surgery, I don't think it's a good idea. As you can see here, the Cresta view shows very normal anatomy, but there is a perforation in the sinus. Another reason Cresta approach is not favorable to many surgeons is that you need to have minimum of 5 to 7 millimeter of initial bone height. Without that, it's very difficult to do a good elevation buccolingually. And as you can see in the slide, you will have a blind spot where you have lack of blood supply, and since it is a bone pressure added elevation, you will end up with dome-shaped sinus anatomy rather than fully elevated membrane between the palatal and the buccal. Therefore, many surgeons prefer to do lateral window technique rather than the Cresta approach. Now, as a young dentist, I was wondering, how can we take out all the disadvantage involved with the previous technique and only have the advantage of the both technique? And simply put, my technique, I think the name describes it, is called Cresta window technique. Why? Because we're simply making window over the ridge. And as you can see in this slide, it's not a blind technique. It's simply a mini version of lateral window technique. And we are simply lifting the membrane from the crest view. And if you utilize the trephine and specialized instrument as I've introduced in this slide, you can predictably raise the membrane without any blind technique nature involved. Another dilemma I had was, well, if we're making window over the crest, how are we going to place implant at the same time? And the solution was solved when I met this implant system called Rescue, which is a super wide diameter implant in 6, 7, or even 8 millimeter in diameter. So for those patients who have not worn dentures, brachyfacial, very square face, they usually tend to have very wide reach. In those cases, rather than opening lateral window, I think it makes more sense to open crestal window, and then after elevation and bone grafting, you will simply insert the implant, super wide implant, and then put a wide healing cover, which is much wider than the implant, in order to prevent accidental implant dropping into the sinus. So in this case, I have a case where on number 14 area, initial bone height is about 1.5 millimeter, and there are some pre-existing infection on tooth number 13. So I went on and extracted the tooth. I waited about 3 months, let the tissue heal. And this is the occlusal view of the sinus after the diamond drill. I will go into detail why this diamond is so critical in my technique, in that it does not perforate the sinus membrane. And this is after elevation of the membrane with the small mushroom instrument and cobra instrument. And as you can see, we elevated up to 13 millimeter from the initial bone height, and we are able to achieve good initial stability of implant because I under-prepped the osteotomy by 1 millimeter from the final implant diameter. But more importantly, we don't want to have bone pressure elevation. What we want to achieve, even though we're doing crest approach, we want to be able to elevate the membrane fully, buccal and palatally. And as you can see on this cross-sectional CT scan, that we have a very well spread of the bone, buccal and lingually. You can even do flapless surgery right after extraction, or you could use tissue punch. In this scenario, what we have done is we have extracted number 2 and 3, and as you can see, it's not a blind technique. You see the membrane moving up and down as you're working through. To simply put, if you know how to do a root canal, canal orifice is about 20 times smaller than what you see right now. So if you could do a molar root canal, this is 20 times much easier than a molar root canal. And this is after we place the implant on the left, and then we put a one-stage approach. This is 6 months later after healing. We uncover, we take out the healing abutment, and we put the stuck abutment, and we take an impression to get a final prosthesis. Now, when you have a multiple sites, such as in this patient, it becomes even easier because you can really manipulate the sinus membrane. As you can see from this mirror image that we are shooting, you could appreciate that this technique, although it's a crestal technique, it is not a blind technique. And the clinician is able to fully see the membrane while he's elevating the membrane. At the same time, you can see that there is a minimal flap elevation, and there's no bleeding involved, and there's not going to be any major postoperative complication. However, the trick here is that you have to pick a case such as this, where the minimal initial bone height is as minimal as possible. Therefore, in contrary to what most people think, less bone you have is actually easier. So this is after membrane elevation. We added bone graft, and we placed the implant. Okay, and this is, as you can see on the post-op x-ray, we elevated about 14 millimeter. So there's no limit as to how much we can elevate. But since we are utilizing super wide implant, there's no really reason to place a very long implant. If you calculate the surface area of this 7 by 10 implant, it's about twice the surface area of an implant of size of 5 by 10. And this is the x-ray 1 year post-op. As I mentioned before, I think it's very crucial to elevate the buccal and palatal membrane so that we don't have a dome-shaped graft right after the sinus procedure. And you can see well-spread bone graft material buccolingually. And we know in this situation we're going to have good blood supply and faster healing and faster turnover of bone into a true bone. Now, I believe that we shouldn't do any blind technique. I think bone pressure elevation is okay. But before you decide to elevate the sinus membrane using bone pressure elevation, you have to make some clinical diagnosis. For example, the slide on the left shows very thin sinus and with some residual bone left over. And in this situation, if you do blind technique, if you do bone pressure added elevation, most likely it's going to perforate because we have a very fragile membrane and it'll be very technically challenging to elevate the membrane without any perforation. However, the slide on the center shows very thick sinus membrane. And in this case, I think blind technique or bone pressure elevation is suitable for this patient because most likely this membrane will take that pressure and go ahead and elevate for you. Now, the slide on the right side is a scary scenario. We have a chronic inflammation of sinus membrane, and elevating sinus membrane in this situation will be a suicide. You're going to have a lot of complication, a lot of inflammation, and you might end up opening another window to take out your graft after you get infection. So in this scenario, what I would do is I would go ahead and remove all the degranulation of tissue. But as you can imagine, removing degranulation of tissue from sinus membrane without tearing is not an easy task. I think doing a blind technique when you do a Cresta approach, it is a bad idea because as you can see, the picture on the left, you have a very thin sinus and you have some bone particles around the sinus membrane as well. If you observe the color of the sinus membrane, it is transparent, which indicates that it is fairly thin sinus. And if you try to do bone-added elevation, most likely it's going to rupture. Therefore, I believe that clinician should make a decision by observing the sinus membrane and decide, are you going to do bone-added elevation or are you going to manually detach the membrane off the sinus wall before you put the bone graft. On the picture on the left, on thin sinus case, you must detach fully and visually check that you don't have any perforation before you add the bone graft material. Now, the picture on the middle, thick sinus membrane, is fairly thick sinus membrane, is in very good quality. Here you can do bone pressure elevation, and I think even any kind of technique that you use in this patient on the middle is going to work fine. So clinically, we need to make a decision by observing the sinus membrane and its thickness before we decide which route we're going to go. Most importantly, we have unhealthy sinus on the right side. Now, as you can see, we have inflamed tissue, and if you remove this inflammatory tissue, now you start to see the sinus membrane. In this scenario, if you add a bone graft and the patient gets inflamed and it blocks the natural ostium, you're going to have a clinical symptom. Patient is going to feel pressure on their sinus, and if you just don't do anything, patient even is going to have a headache and too much pressure around the maxillary sinus, and they will come to you next day in the morning. So in order to prevent that, you have to make a clinical diagnosis before you add the bone graft. Is this healthy sinus membrane or unhealthy sinus membrane? In unhealthy sinus membrane, I will abort the procedure, put the patient in medication, and then come back later on to do the sinus grafting. Like I said at the beginning of the lecture, I think there needs to be a new criteria for deciding whether we should do a crestal or lateral approach. We should not depend on initial bone height as an indication whether we should do lateral or crestal approach. Rather, buccal-palatal dimension of the ridge should really dictate whether you're going to do crestal or lateral approach. If you have more than 9 millimeter, and that's my magic number, if it's more than 9 millimeter buccolingually, there is no reason to open lateral window because you can simply open crestal window. If you really think about it, same thing. Crestal or lateral is just a matter of how you approach it. However, when you have a narrow bone, less than 9 millimeter, your crestal window will be too small. In a sense, it will be too difficult to introduce the instrument and too difficult to have any kind of visibility. Therefore, I recommend to do the lateral window technique when you have the narrow bone type. I further divide the wide bone category into two subcategories, and one is crestal window technique, and another one would be the bone pressure sinus elevation that I described earlier. Now, crestal window technique is much easier, once again, because you have a better access, better visibility compared to initial bone height of greater than 5 millimeter. When you do crestal window technique with very low initial bone height, all you have to do is use the diamond drill, mushroom, and the cobra instrument, and once again, you're not going to have any problem in access to the buccal or the palatal membrane. It is very important when you choose the implant system that the implant is wider at the platform, because some implants are narrower at the platform, and if you use that kind of implant and you only have 1 millimeter residual ridge, by the time you finish inserting the implant, you have the danger of dropping the implant into the maxillary sinus. Then it's going to be an emergency. You're going to have to open the lateral window and take that implant out. So make sure that when you choose the implant system, you select the implant that is wider at the platform so that you gain initial stability from the crestal ridge. And also try to select a healing abutment, as I've shown here, which is much wider than the implant itself. And that will work as an insurance for you. That will prevent implant dropping into the sinus, especially if patient is wearing denture and so on during the healing phase. If you have greater than 5 millimeter bone, I recommend you to use trephine to collect the bone so that you could put that bone back into the sinus, and using the reamer and the mushroom and the tapping drill to slowly do bone pressure elevation of the sinus. Let me show you a case involving the crestal window technique. Typical case that I recommend is this type of case where you only have 1 millimeter of the initial bone height. Once again, most people think that this is very difficult case, but rather this is the most easy case. Why? It's easier to see and you have a much better access compared to when you have greater than 5 millimeter of initial bone height. Now, incision, however, is very important, and you must not make crestal incision because we're making window over the crest, and if you, in case you perforate and you try to close, you're gonna have a window right below your incision line, which is not a good idea, and that you could end up getting oroanchular communication, and that's something that you don't want to deal in your practice. So what I recommend is a palatal incision. Why? In case you get a perforation, you want to be able to close, and you want your margin of the flap to be at least 2 millimeter away from the window side. So this type of incision is suitable for my technique. I would never do a tissue punch or a crestal incision, once again, because we're human beings, we're doctors, we're not God. You will get perforation in my hands about 20% of the time. And in those 20% of the time, we don't want to risk having oroanchular communication. So palatal incision is very critical. And this is after flap reflection. I will use the diamond drill, try to select as wide diameter as possible because pressure equals force divided by area, and bigger the diameter is going to be more predictable for you. After you do that, what you will find is you will have a very thin, paper thin piece of bone protecting the membrane. You could just remove that with the cotton plier as I have here. Now I have very healthy sinus membrane looking at me, and the sinus membrane looks very thick. So in this case, I think even blind technique would have worked. But once again, it's important for the clinician to make that decision rather than just doing blind technique all the time. So here I will elevate the membrane. I will detach the membrane off from the sinus using the mushroom. And this is what I'm doing. And afterwards, I will use an instrument called Cobra, which looks like a cobra. That's why I named this Cobra. And then you further detach. Now, this is very important part of the procedure where you want to see a lot of bleeding. So what I'm doing is I'm introducing Cobra into the sinus and I'm scraping the internal wall of the sinus. Why? Because I want to promote a lot of bleeding. If there's not much bleeding inside the sinus, then most likely, you might get infection during the healing phase. So I try to promote as much bleeding as possible from the sinus internal wall. This is after implant placement. Remember, initial bone height was only about 1 millimeter, and as you can see, I could gain good initial stability. And the key here is to underdo your osteotomy hole by not less than 1 millimeter. So if I'm placing 7 millimeter implant, my last drill will be about 6 millimeter, and that will have a perfect fit with very good initial stability. This is 6 months later. I will put the stock abutment, and then this is after delivery of my prosthesis. Let me illustrate to you. As you know, when you go to the courses, you do a lot of egg lift to practice how to do a sinus lift. And piezo is great, but it takes too long. As you can see here, it takes about 3 seconds to go through a hole. 1 second, 2 seconds, 3 seconds. So here in 15 seconds, I drilled 5 holes, and none of them, as you can see, have any kind of perforation. This is so predictable and it is so efficient. And the real secret, the real idea I got from was the nail bed. When person is lying down on the nail bed, it doesn't hurt because it's spread over large surface area. Pressure equals force divided by area. So bigger the diamond drill you have, it's going to be more predictable in terms of not putting too much pressure on the sinus membrane. So when I do lateral wall, when I have a thin lateral wall, I will use the same instrument that I use for the crestal sinus, and simply just grind until you feel your diamond drill drop into the sinus. And afterwards, you see a nice sinus membrane. As you can see, we even have a small arteriole, which did not rupture. It's relatively fast. Then I will take the smallest mushroom. I go around 360 degrees to detach the membrane little bit by little bit. And then I introduce bigger mushroom to detach the membrane furthermore. After I do this, when you do the lateral window technique, it's very important that your window location be as medial as possible. Why? Because your instrument is coming from anterior and posteriorly, you always have good vision towards the back, and you always have good access towards the back. However, backwards, it's very difficult to introduce the instrument towards the anterior portion, and you always have indirect vision in that location. Therefore, if you perforate, most likely it's always the anterior portion of the sinus. Same thing when you do crestal window, you want to start out from most lowest location, because we are elevating sinus from bottom up. Therefore, if you start from the top and try to elevate downwards, it is very difficult, and you have too much tension on the membrane, and you will rupture. So location is very important. Just like the real estate, it's all about location, location, location. So in this scenario, I want to make my window location as medial as possible. And what I do is I will use my mushroom instrument to pry away the bone. Because in this case, sinus wall was fairly thin, and what I would do is I will pry away the sinus wall little bit by little bit until I am at the most mesial surface as possible. Okay. Once I do that, I will insert any instrument of my choice. You could use Cobra or you could use any other instrument, and you ask the patients to breathe and you observe. You could confirm that you have not perforated the sinus. Okay. So it's fairly easy procedure. I mean, even lateral wall, I think if you do it really fast, it could be minimally invasive. Now, if you have more than 5 millimeter of initial bone height, I recommend you to use this trephine called ASBE. It stands for Adjustable Stopper and Bone Ejector. Why? Because the shank, which is inside the trephine, work as adjustable stopper, because you could adjust so that you don't perforate beyond your estimated length. Not only that, taking this bone piece out from the trephine was very difficult task. Sometimes bone density is so hard, such as on the mandibular ramus or symphysis area, it is very difficult to remove this piece of bone. But by having a shank that could run inside the trephine, if you run the handpiece, you could remove this piece of bone in controlled fashion instead of trying to pry this out from the trephine. So let me summarize crestal window technique. I think it should be the gold standard in sinus grafting because it gives less morbidity for the patient. Every incision is within keratinized tissue, and we are dealing with alveolar bone instead of basal bone. And surgery is you have much less bleeding and much less postoperative swelling and discomfort. And it is the only crestal approach that is not a blind technique. There are many crestal approach out there, but they are all blind technique, and I really truly believe that we should not do surgery with our eyes closed. So I'm not a big fan of blind technique. That's why I said crestal window technique should be the standard of care. And because we can see, we could even repair the small tear of the membrane. There are techniques to move around septums, and the best about there is no malleting involved. I mean, you don't have to hammer anybody. I think that's the best part of this procedure. However, you must understand that indication for crestal window technique is completely different from what most people think. It does not depend on the initial bone height. Rather, it really depends on the bone width, and less bone height you have, the better. Why? Because you have better visibility and better access to your sinus. This is the only system that will let you elevate the buccal and palatal membrane so that you don't have a dome-shaped, bone pressure elevated graft. Rather, you have a very nicely distributed bone graft touching the buccal and the palatal wall so that you maximize the blood supply to your bone graft. And you could collect autogenous bone using the ASBE trephine that I put into this kit. So typically, another very common question I get from the attendees are, how long do you wait, doctor? And my answer is typically anywhere from 6 to 9 months. It really depends on many factors. Number one, how is the healing capacity of the patient? And number two, how wide is the bone? Obviously, if you have a wider sinus, then it's going to take much more volume of bone graft and much more time for the bone graft to turn over into host bone. If you have a younger patient versus grandma, then obviously younger patient will be healing at much faster rate. But typically what I do is after I do the bone graft, I wait until I see the new cortical bone on top of my graft, and I will show you what I mean through this patient. Here I will locate the lowest point, which was number 15 area. Once I introduce the bone graft, I will try to condense the bone laterally using my spreader instrument, buccolingually, but also mesiodistally, and I will place 2 more implants anterior to that. as you can see here, what I look for is every time I take X-ray, I look for disintegration of old cortical bone, sinus floor, and when I see the new cortical bone forming on top of my new graft, which you see here, then I will go, now I know my graft turnover into the host bone, and I will start loading the implants then. So it really depends, anywhere from 6 to 9 months, and you are looking for the new cortical bone forming on top of the graft. I did histology after histology. All you find is bone. Okay, you see the live cells in the lacunae, osteocytes in lacunae. So it's a true bone. And I like to use FTB for this purpose. Sometimes you have to do lateral window technique, and I want to show you this funny script that I found from YouTube.
Ariana, за всеки шатен.
Now, as you can see here, if you use the bottle opener to open the beer bottle, it's much easier compared to opening a beer bottle with the hand. And I think we've been trying to do a lateral window with, there are many, many techniques, but I think we've been trying to do it in a difficult way. So I was thinking sometimes we have to open lateral window. When you have less than 9 millimeter buccal lingually, then what do you do, Dr. Lee? You can't do crest of window technique. Then I want to introduce you one technique that I use. I call this beer bottle concept. So what I do is I will mark with my trephine that I explained earlier to Dr. Garber. I have 3 trephines in increments of 0.5 millimeter. And once I mark the sinus wall, I will do a little bit of malleting to engage my beer bottle opener and then really pry out the sinus wall. And let me show you clinically what I mean by that. So this is typically, I'm not afraid to make 2-3 sinus window because you could make it very simply, very fast and very predictably. So first of all, you need to mark, you need to use the trephine to mark the indentation. And then what I will do is, as you can see here, I will introduce my beer bottle opener. I call this window opener. And then just pry away, just like opening beer bottle. Okay, so very fast. If you know how to open a beer bottle, I think you'll be able to do this procedure. Once you have done that, you could go ahead and you will have a scenario like this where you have an intact sinus membrane, and you will go ahead and elevate the membrane as the techniques that you normally use. Same thing here, I open 2, but it's not necessary to open 2 as long as you make the open as mesial as possible. And instead of putting the membrane over the sinus window, I simply put back the window that I got so that you save some dollars because you're not putting any membrane over the, and you have the best membrane here, patient's own bone. I think that's the best membrane. Now, what if you have a septum? And this tool is so powerful that I want to show you. In this case, I opened the first window okay, but the second window, it was really resistant to removal. And then I use all my force, and as you can see, even the septum comes out from the sinus wall. So this really works really well. And as you can see, the wall of the septum came out with this window opener, and you could appreciate that membrane around the septum still intact. So very, very cool procedure. If you're gonna do lateral approach, I recommend you to find a system where you could do it in predictably and as quickly as possible to minimize the trauma to your patients. So I would like to end this short presentation by giving you 3 take-home messages. Number 1, I think we should do Cresto approach whenever possible. I think that's the best for the patient and even best for you because it's much easier, less invasive, less bleeding, is just more advantageous than a lateral window technique. However, you need to have that buccolingual dimension of 9 millimeter. So therefore, always look for that. It's not the initial bone height that is important. It's actually rather buccolingual dimension that is more important in deciding whether you're going to go lateral or crest to approach. If you have to open lateral window for many reasons, I recommend you to find a system such as beer bottle opener concept so that you can predictably and as quickly you open the window and finish the procedure to minimize the postoperative trauma and infection for your patients. I would like to thank Dental XP and Dr. Garber and Dr. Salama for having me here. If you have any question about my procedure, you're more than welcome to email me. If you are interested in my upcoming seminars, please log on to www.firstchoicedentalgroup.com/seminars. We have many live surgery seminars that we offer. Not only we have those seminars, but we also offer a seminar where the attendees can do surgical procedures as well. So please check it out. And if you have any question, please shoot me an email, and I'll be more than happy to respond to those questions. Thank you very much.